Consumer Reports. I'm a longtime fan of Consumer Reports. I never buy a vehicle without checking with Consumer Reports. It now appears that I should never purchase a prescription drug without checking with Consumer Reports. Ms. Gill led the secret shopper investigation and is also part of the organization's Choosing Wisely and Preventing Overdiagnosis campaigns. Our second witness, Pooja Babra, is the practice lead at Point of Care Partners. She will testify about technologies and tools that assist patients in securing the prescription drugs they need at the lowest possible cost. Next, we will hear from Dr. Stacy Dusetzina, who, did I do it right? Good. Who is an associate professor of health policy at Vanderbilt University Medical Center. She is also an author of the 2017 National Academy of Sciences, Engineering, and Medicine report entitled Making Medicines Affordable, and a brand new article on the prescription drug pricing challenges that was just published in the Journal of the American Medical Association. So that literally is hot off the presses, and we're very delighted to be the first committee to spotlight your research in that area. Our final witness on the panel today is Jane Horvath, the principal at Horvath Health Policy. She too is expert in this area and will discuss state efforts to advance transparency for prescription drugs. I thank you all for being here today, and we'll start with Ms. Gill. Thank you.
Good morning. Thank you so much for having me here today. Chairman Collins, Ranking Member Casey, and committee members. We appreciate the opportunity to be here today to discuss the findings of our recent special investigation on the cost of drugs for seniors covered by Medicare Part D plans. I speak to you today as a journalist who has had the honor and actually truly a dream of working for a decade on behalf of consumers at Consumer Reports. My work has focused on healthcare and specifically looking at consumer drug costs. Consumer Reports is an 80-year organization. It's an 80-year-old independent nonprofit member organization. As you point out, we test cars and refrigerators and microwaves, and we rely on evidence-based testing and ratings, rigorous research, hard-hitting investigative journalism, public education, steadfast policy action on behalf of consumers' interest. And that's exactly why last summer, when we noticed a small study coming out from researchers at Yale School of Medicine that suggested some medications might be less expensive if a senior decided to not use their prescription, their Part D plan. And so we decided to take a closer look. So we wanted to replicate what a consumer would experience when they sign up for a Medicare Part D plan for the plan year 2019. So we often use secret shoppers as part of our investigation and actually really as an approach to gathering retail prices of medications. So we gathered a list of 5 common generic drugs, and that included generic Lipitor, generic Celebrex, generic Cymbalta, generic Actos, and generic Plavix. These are typically fairly low-cost drugs. And then we selected 6 mid-sized cities in the United States to run this test: Seattle, Denver, Des Moines, Dallas, Pittsburgh, and Raleigh. And then we chose a zip code in each of those that was close to the city's center. So we logged on to the Medicare.gov website, and we used the Medicare Plan Finder tool just like any other consumer would. And we entered the 5 drugs in each of the zip codes, and then we selected the 3 least expensive plans that we wanted to really look at. And then we compared what a consumer would pay with the 3 low-cost plans with 2 different pharmacies in that zip code. And this is important because there's a lot of pharmacies and zip codes, but you can only compare 2 at a time. And needless to say, and one of the reasons I'm here is because we did not expect to find what we did. Instead of identifying medications that might be less expensive if you skipped using your Part D plan, we found that what consumers could pay for their medications could vary by hundreds of dollars. And worse, if you made a small mistake while signing up, it could cost a consumer thousands of dollars. And here are 3 quick examples, and I'll draw your attention to slide 1, please. So if you accidentally forgot to enter one of the drugs into the Plan Finder tool, it could be extremely expensive. We deliberately left off one drug. So we've signed up with a plan with 4 drugs, and the most egregious example was coming out of Des Moines. The annual drug cost for 4 drugs came to $407, which is actually a pretty good price, and that was with a plan called Cigna Health Spring RX Secure Essential, which sounds very promising until you add the 5th drug, which is, in our case, we left off generic Celebrex. And when you add that drug, the plan price, as you can see, jumped to $2,948, which is an astonishing amount. What we learned is that drug was actually not covered by the plan. And not only that, they would charge a consumer $212 a month for that drug. Just even before I came to this hearing, I wanted to double check just to see how much it would cost. I went to goodrx.com, which is a very common discount website that we suggest consumers try. I found that drug for $16 at Costco, $16, not $212, or $6 at Kroger. So you think about that. That is crazy. Okay, the second thing that we found, this is slide 2. If a consumer picked a pharmacy that's simply convenient, they could wind up spending a lot more money. Our example comes out of Denver. The total cost of the 5 drugs that we tested at a Walgreens was $1,687. Not a great price, but it was okay. But 4 miles away, in the same zip code, same plan, same drugs, at Cherry Creek Pharmacy, which is an independent pharmacy, the total cost for the year was a mere $688, nearly 3 times less expensive. All right, the third thing that we found, and this is for slide 3. This is a general slide just showing the price variation in the 6 cities, but we learned too that if a person focused only on the deductible amount, they could overlook much cheaper plans. Our example comes out of Dallas. One plan with a low $100 deductible. And I'll remind the committee that a deductible is the amount that a consumer must pay before the insurance kicks in. That $100 deductible plan would actually cost a consumer $1,592 for the entire year for those 5 drugs. But another plan in the same area with a $415 deductible would actually cost a person just $574, which turns out to be a pretty good price. These results helped us formulate some consumer tips, but there were 3 quick specific problems I'd like to point out to the committee. First off, it was very difficult to untangle how well any drug was covered by the Part D plan. The second thing is that these preferred pharmacy agreements between a store and a plan meant that this is what generates these insane price differences within the same zip code. And by the way, it was extremely difficult to tell when you were signing up for a plan which is actually the preferred pharmacy. It disappears as you go through the tool. And then the third and final thing is that having a preferred pharmacy could mean that your favorite pharmacy in your zip code, where you've had a relationship with those pharmacists for many years, could charge for the same 5 drugs 2 wildly different rates with 2 plans. And our example again comes out of Denver. 5 drugs, same pharmacy, 1 plan, $524. Another plan, $1,686. So it's clear that it is essential for consumers to have clear, comparative, easy to understand information, and we are pleased this committee is looking at the topic. Thank you again for the opportunity to testify on this important issue for consumers.
Thank you so much for a truly fascinating presentation. We'll now go to our next witness, Ms. Pubra.
Thank you so much, Mrs. Chairman, Ranking Member Casey, and distinguished members of the committee. Thank you for inviting me to testify today. My name is Pooja Babra, and for over 2 decades, I've worked in the healthcare technology industry, primarily focused on e-prescribing and e-medication management. I'm currently a senior consultant with Point of Care Partners, the leading management consultancy focused in this space, and we've been working on real-time pharmacy benefit checks since 2014. Now, we're here today to talk about prescription price transparency, and I'll focus my comments specifically on the real-time pharmacy benefit check transaction. For your reference, I've included historical context and technical details in my written testimony. Now, I've been around long enough to remember that in the early days of e-prescribing, back in the late 1990s, and we've certainly come a long way since then, with availability of electronic tools and information to help prescribers choose the most effective, appropriate, and cost-effective medication. But there's still key missing information at the point of care. The real-time pharmacy benefit check transaction is really in response to prescriber challenges at the benefit information that's being provided in the electronic health record today. Real-time pharmacy benefit check helps fill an information gap around transparency, but its value goes far beyond that. The transaction standards being developed by NCPDP, the preeminent ANSI-accredited standards development organization for prescription transactions in the ambulatory, long-term care, and post-acute care settings. The transaction can actually provide crucial information to facilitate conversations between the physicians and their patients around their medications. Now, this can include patient out-of-pocket costs, any alternative medications that may be more affordable for the patient, the best place to fill their prescription, and also insights into additional requirements that may be required, such as prior authorizations. Now, the goal around this is to provide more accurate information about the patient's prescription coverage and the cost of their medication in the physician office, as opposed to having the sticker shock at the pharmacy counter. Now, studies have shown that cost is the #1 reason that patients are abandoning their prescriptions and not adhering to their medication treatments. In other words, the provider prescribes the medication, but the patient doesn't fill the prescription, or the patient fills the medication and then only takes a partial dose because it's too expensive to get a refill. And we heard some of those stories yesterday from the patient testimonies. Now, both of these scenarios will likely lead to greater healthcare costs down the road, leading to additional office visits, unwanted ER visits, and potential hospitalization. But by providing insights into the cost of the medication to the prescriber, we believe that real-time pharmacy benefit check will enable prescribers to ensure that the prescriptions that are written actually get filled and the patients are taking them as prescribed, which will in turn lead to greater public health. Now, there are a few shortfalls with the real-time pharmacy benefit check as it's being deployed today, including the lack of information about potential cost savings, discount programs, and other financial support programs. It's also important to note that the transaction only provides the pricing on a patient's pharmacy benefit, not their medical benefit. And often expensive specialty medications are actually covered under the medical benefit, and the real-time pharmacy benefit transaction will not show that pricing. Use of the real-time pharmacy benefit check is also somewhat limited in scope today. It's primarily used by prescribers through their electronic health records. And we believe that it's important to expand the reach of this transaction to the patient and the patient caregivers. Finally, we believe the real-time pharmacy benefit check should be expanded to incorporate additional information related to patient out-of-pocket costs for the drug. Specifically, patients and their caregivers should have information that will help them determine whether they should obtain their medication under their prescription benefit or pay cash at the pharmacy. Tremendous progress has been made with the development and utilization of the real-time pharmacy benefit check, but to date, the business cases have been focused on payers, PBMs, and the providers. And we're confident that widespread use of the transaction will yield a public health gain while at the same time enabling patients to receive their medications at the lowest possible cost. I thank you for the opportunity to testify today, and I'd be happy to answer your questions.
Thank you very much, Ms. Barbara. Very much appreciate your being here today. Next, we're going to go to Dr. Doucette-Zena.
Thank you so much. Chairman Collins, Ranking Member Casey, and distinguished members of the committee, it is my pleasure to be here today to testify on this important topic. My name is Stacy Doucette-Zena. I'm Associate Professor of Health Policy and Ingram Associate Professor of Cancer Research at Vanderbilt University School of Medicine. My research focuses on prescription drug policies that facilitate and impede the use of these important products for patients. I also had the honor of serving on the National Academy of Medicine's Committee on Ensuring Patient Access to Affordable Drug Therapies, and that report was published last year. My research includes findings related to the role of drug rebates for increasing patient and taxpayer spending in the Medicare Part D program, how having higher out-of-pocket costs for patients is associated with lower use of needed medications, and how prescription drug list prices and price increases have made many drugs unaffordable for Americans. In the United States, many patients are facing the reality that prescription drugs are no longer affordable for them. Our work, for example, has shown that in the Medicare Part D benefit, that it requires patients to pay a percentage of the drug's high list price for virtually all anti-cancer drugs. This means that patients will spend thousands of dollars out of pocket when they fill their first prescription. Like Ms. Holt, who was here yesterday talking to the committee, filling Revlimid, this drug costs the Medicare program $21,000 for a 28-day supply today, and it would cost a patient filling the drug for the course of a year over $15,000 out of pocket, and that's for only that one drug. This high level of spending has also been shown across other disease areas for patients needing complex treatments. Commercially insured patients are also exposed to high out-of-pocket spending, so this isn't only a Medicare Part D problem. Deductibles and coinsurance, where patients pay the full price of a drug when they fill it, or when they pay a percentage of the drug's list price, have become much more common in both commercial health plans and under the Medicare Part D benefit as well. Under these arrangements, patients are being asked to pay based on a drug's list price, which can be much higher than the price that is paid by the PBM or the health plan itself. As an example, a patient filling an 84-day course of hepatitis C treatment, a very important curative therapy, would have their out-of-pocket cost under Part D calculated based on a list price of $93,000. Instead, their health plan and PBM are likely to be paying closer to $35,000 for that same product. Now, it would be beneficial to share that lower price with patients and have their costs calculated on the lower post-rebate price, but I argue that this would also result in a significant financial burden. Best case scenario, patients paying on the $35,000 price would still have to pay out of pocket over $4,000 to fill that drug. I think that's very much unaffordable for many people. Insurance should be designed in a way that protects people from financial catastrophe when they're sick, and today's Medicare Part D program does not do that. Instead, patients who need expensive drugs or who need a lot of drugs are exposed to unlimited out-of-pocket spending on the program. Congress and the American public have heard and will continue to hear from stakeholders within the supply chain, and they all will point to one another as the key problems, but in fact they are all part of the problem and they all need to be part of the solutions. This is a complex area, so solutions are also going to be complex. But when considering solutions, I would recommend the committee focus on three key goals. The first would be that we should ensure that patients have access to high-value drugs at a reasonable out-of-pocket cost for them. The second is to consider ways to remove incentives that are in the system for high list prices and price increases. And the third is to reward innovation, true innovation by pharmaceutical companies by paying for value. I thank the committee for the opportunity to be here today, and I look forward to working with all of you on solutions and look forward to your questions.
Thank you so much for your testimony. Ms. Horvath.
Thank you, Madam Chairwoman, and Ranking Member Casey, and members of the committee. I really appreciate the opportunity to be able to talk about this complicated but very important topic today. So my name is Jane Horvath. I'm currently a consultant, and I work pretty much exclusively with state legislators, state agencies, and state national associations, too, on describing the drug financing and supply system so people can understand it, but then also on cost containment policies. And specifically, I've worked with California, Nevada, and Oregon on their transparency implementation and/or their legislation and/or their implementation. Transparency is a really important first step in managing drug costs. Transparency has improved the policymakers' understanding of how things work and understanding what they still don't know how it works, but it's an opportunity to figure out how things should work. States and federal government have taken really important first steps, in my view. On the federal side, CMS has the dashboards that Senator Casey referenced a minute ago for Medicare and Medicaid, and even rebate information on Medicare, which I think is really important. And CMS also has the National Acquisition Cost Database, which is a great research tool for policymakers and researchers. There's nothing else like it that I know of. And for states, they have done transparency and are doing transparency on drug prices and drug price increases, transparency on insurer drug spending, net and gross as a percentage of premium. It's all very interesting data. And more recently, transparency on the PBM business model and how that impacts the whole financing chain. And just so you know, I tend to think of things as the supply chain and the financing chain, and it does untangle the web a bit and makes things a little clearer. So that's how I will discuss it today. So these have created really important discussions everywhere. But today, I advise states, if they ask me, not to pursue any further transparency legislation. We have 8 states now with very good transparency legislation. Maine is implementing transparency legislation. Vermont has excellent legislation. Oregon and Nevada have good, and California. And almost everything that the states are collecting is going to be public. So, I think states don't need to spend a lot of resources reinventing these really complex databases to capture and release this data. And I think that feds can help states do more. I think it would be really interesting to ask the Office of Personnel Management for their plans to produce very similar data to what the states are producing, insurer, PBM, manufacturer. I also think it would be really important in Medicaid to understand which drugs in the Medicaid program are rebating at just the federal minimum. I mean, it's not a minimum, but the federal floor, the rebate. I think that'll tell us about drugs that, where there might be deep discounting or not among some high-cost drugs, it'll show us some consumer behavior without releasing any proprietary data per se. And then I think looking at in Medicaid again, there is a cap in what a manufacturer's rebate liability is at 100% of really the market price. And they get to that cap basically after they've had a whole bunch of price increases. So even if you follow the formula to the end, the rebate might be 140% of the market price of the product, it's kept at 100. And I think it would be really interesting to know how many drugs and which drugs have reached that 100% cap in liability. That'll tell us something about price increases, I think, industry-wide. And I'd like to very briefly move beyond transparency, because I think transparency is the first step. And federal law and federal case law really do hamstring states in their ability to really affect consumer costs of prescription drugs. But there are a couple things that I think the federal government can do to really open up state financing innovation here. And one would be to expand the list of countries from which state programs can import drugs. This would certainly help Florida, since Florida's population is almost the size of Canada's. Clarify that patent law does not limit state ability to regulate patented prescription drugs. And exempt from Medicaid best price state programs, sort of large state cost control programs, innovative programs. In Q&A, I can explain why that would be important. And then finally, just to uncap that Medicaid rebate liability that I described a few minutes ago. So that's it. So thank you.
Thank you so much for your excellent testimony. Ms. Gill, I want to start with you. I thought it was so interesting as you went through your charts that not only is the choice of plan important, but also the choice of pharmacy. And I don't think most of us think about that the differences in price may occur at the pharmacy level as well. So that was really very illuminating. I remember how shocked I was when a group of pharmacists in Maine came to meet with me and told me that in some cases prescription drugs would be less expensive if the consumer did not use insurance. That just never would have occurred to me. Based on your investigations of prescription drugs that seniors commonly take, could you give us some idea of how often you found that the price would actually be less paid out of pocket rather than using insurance?
Sure. So out of the 18 plans that we looked at across the United States, in total, about 18% of the time, it would have been less expensive if someone went outside of their plan. Now, what's important to note is that we actually don't typically recommend that because you really want that amount of money that you're paying to go toward your deductible. But it just depends on where you are as you're reaching the donut hole.
That is amazing, but you're right. The downside is that it doesn't count toward your deductible. Doctor, I want to talk to you about a comment you made about our need to remove the incentives for high list price. I'm very intrigued by this because as I look at the system, part of the problem is how pharmacy benefit managers are compensated. And if they are compensated through the rebate and as a percentage of the list price, and the pharmaceutical company knows that the pharmacy benefit manager is going to make the decision on whether or not their drug is included in the formulary of the insurer, isn't that an incentive for the pharmaceutical manufacturer to keep the list price high?
Absolutely. So right now there are incentives in that whole web that you projected earlier for everyone to have the list price be high. So we've shown in our work that as the list price increases, that it benefits the drug manufacturers, it benefits the pharmacy benefits managers, and in some cases benefits the health plans because of the way that Part D is designed. It does not benefit the consumer, and it also does not benefit the taxpayers because most of the spending, once people have hit the catastrophic phase of the Part D benefit, is going to be paid by taxpayers through the reinsurance part of the benefit.
So if you change the compensation for pharmacy benefit managers so it was fee-based rather than a percentage, would that help?
So I think we need to move away from percentage-based payments for pretty much everyone in the supply chain, not just PBMs, physicians as well. But yes, I think that could help in some ways to just pay a flat fee for those services rather than paying based on the spread pricing or paying a percentage of list price. I think that would absolutely be a step in the right direction.
Ms. I'm sorry that I keep having trouble with your name. Barbara?
Yeah.
I saw you nodding. Is that correct? Do you agree with that assessment as well?
Yeah, well, I just think that, the fee-based is, we need to start really looking at outcomes as opposed to actual fee-based pricing, in my opinion. And I'm here to talk about the technology, but I do agree with that statement as well.
Thank you. Senator Casey.
Thank you very much. I want to start with Ms. Horvath on the question of transparency. As I indicated earlier, at least implicitly, there is one thing, maybe only one thing, that the Obama and Trump administrations agree upon, and that's that the cost of prescription medication should be available to the public. That's the dashboard issue in legislation I mentioned. This started with that administration maintaining an online drug dashboard, including a snapshot of average spending for any given year and over time for hundreds of prescription drugs. Obviously, we need to keep that updated every year. The legislation that Senator Collins and I are working on would ensure that no matter who's in the White House, we all have access to this information. Just a basic question on this. Do you think that drug price transparency has and can impact the cost of prescription medication?
I don't think it does. I think what it does is inform conversations and discussions and policy making about how then to constrain the cost of prescription drugs. So, California had this, and Oregon and Nevada, they have, very substantial bills on reporting price increases over a threshold and stuff. But manufacturers are reporting those price increases over those thresholds. They're not constraining themselves so that they don't have to report.
So you think the key is what? To combine transparency with what?
So actually, I think there's only really a few ways to make sure that on the financial side, the transactions, the benefit of rebates and everything else get to the consumer at the point of service. It is a controlled importation program, or like I'm working on with several states now, setting all-payer upper payment limits. So, once you do that, you are able to watch and monitor for competitiveness in the system, watch and monitor for price increase, people taking margin basically on the price of the drug. And I think when you do that, then you can move more to fee-based, paying people for their services by fees instead of percentage basis on the cost of the drug. And I wanted to just say one thing about eliminating PBM rebates. To the extent that the PBMs pass through those rebates to the health plan, that goes basically to offset the cost of the premium. So, they do serve an important function, and to just, shut that off means that premiums will rise because we don't necessarily know that the drug cost is going to go down. So I just throw that one caveat out there about eliminating rebates.
My next question, Doctor, for our testimony yesterday on the cost as it pertains to individuals, we know that, and I focused a little bit in my opening about the one category of folks who are both seniors and low income. They're the most likely to face these difficult choices that we've talked about. Some of the lowest income seniors who are both low income and have no savings can qualify for a federal assistance program, which has been called, the vernacular is extra help, to cover some of those costs. But even with extra help, high coinsurance costs or high coinsurance rates can put needed prescription drugs out of reach. Can you tell us what your research shows about seniors who qualify for this so-called extra help program but still struggle to afford their medications?
Absolutely. Thank you for the question. One of my trainees has actually done some work on this area, and it's the first study that I'm aware of in this space looking at individuals who qualify for the partial subsidy or extra help. And what we found were that for people who were taking certain cancer treatments, that those who were in the extra help program actually did worse than people with no help or who had Medicaid. And when you look at the benefit, you can see why. So right now, the extra help benefit asks people to pay 15% coinsurance for their drugs. Now, we were studying drugs that cost upwards of $10,000 per month, so you can imagine if you have very little savings, you almost qualify for Medicaid, but you don't, that you could find yourself being completely priced out of those important drugs.
Thanks very much. I know I'm over time. Thank you.
Senator McSally.
Thank you, Madam Chairwoman. I appreciate you holding this hearing on this important topic. There's so many people in Arizona, seniors and others, that are really struggling to afford the prescriptions that are life-saving prescriptions, so I appreciate all the testimony today as we try and solve this issue. There's one, for example, my team informed me of, named Jean, who's a senior resident currently taking 7 prescription drugs for various conditions, lives on $899 a month from Social Security, her only source of income. She has to cut back on food, cannot make repairs to her home, has no income left for anything else. She says the only way she can exist if she runs up large debt on her credit cards. She's expressed she needs these drugs to live and cannot go without them. And increasingly, more and more seniors we see are having to choose between prescription drugs and their other, payments for just surviving. In Arizona, many people are then going to Mexico in order to get access to medication they need. And we have other reports. It's been reported in Arizona 100 different medical practices have been implicated for black market supply chains with counterfeits that people are turning to because they can't afford the drugs at the pharmacies. There was a citizen of Arizona named Betty Hunter, had lung cancer, received a counterfeit infusion of a cancer-fighting drug, and in the end, the FDA found the medication contained water and mold. Ms. Hunter died a few weeks later. So this is what's happening to people because they can't afford the medicines they need to stay alive. They either have to choose between food or their medicine, or they've got to go to Mexico to get it, or they're relying on counterfeit drugs. I mean, this is not acceptable, and I appreciate all of the discussion on what we need to do to bring down the cost of drugs, but then also make it transparent. I know it's a complex issue, but why can't we have an Expedia.com of prescription drugs? So even if you're trying to get it from a pharmacy, you can at least look at when your doctor says, which one should I send it to? And the answer is like, I don't know, this one, or this one, that you can actually look and see which one is going to be the cheapest for me, and then send it there. Like, what barriers do we need to just provide that basic transparency so people can shop around? Anybody want to jump in on that?
So I'll take that. So the real-time pharmacy benefit check that we now can offer to physicians, it's currently available between the PBM and the physician in their electronic health record. But part of the issue with that is it's only giving you the cost under insurance. So right. It's great information, and the workflow today is you do usually have a favorite pharmacy that you're going to. So when the physician checks that price, it's going to show you the price at that specific pharmacy under the insurance coverage. But we're actually working, there's an organization called the Caring Alliance, which is a bipartisan organization that's looking to bring this real-time pharmacy benefit check to the patients. Right. Exactly. And as we heard, the cash price may actually be better than what's covered under your insurance.
Exactly.
And so you would be able to, basically shop around, figure out that cash price. But then the other piece is, if you pay cash at the pharmacy today, the insurance company may not know that. So we really need to be looking to close that loop, because they may not know that right. You've actually picked up that medication.
Right. I mean, we should be able to type in your zip code, just like everything else we do, search within 10 miles, and then figure out what the cost is going to be, and let the patient choose whether they want to pay cash or have it go towards their deductible. This is all about patient choice, patient transparency and competition, so that they're able to afford their basic medicines.
I would underscore that by saying that based on the research that we've done, as well as multiple other stories besides this investigation on Medicare Part D plans, I would sum it up by saying that it's a game for consumers, and it's a terrible game.
Yes.
And so while I appreciate the concept of transparency, we have to have it. It's a function of being able to make a clear choice. At the same time, we are asking consumers to run around, check apps, look at websites, call pharmacies. The amount of administrative burden required to figure out what is the least expensive price. I mean, I make a career off trying to tell people right. Where to find it and how to do it. But at the same time, there are the mechanisms in place to allow that are just, that's what has run rampant. And whether it takes rules, laws, regulations to stop it, probably what.
Yeah. So what barriers do we need to remove? We do this for literally nearly everything else in our life. Type in your zip code, pull up the numbers, click on the one you want. What am I missing?
So, you know, it's complicated because the consumer isn't necessarily the one paying the largest part of the bill. So the insurance company has a role, and I think that's one thing that makes the technology so different, is because you're trying to take into account all of these factors. You know, I think that the point of, you know, if Consumer Reports, whose job it is to investigate these things, found it to be incredibly difficult to be able to find the drugs at the lowest price, I think it really highlights that we should have policies in place that make it pretty straightforward for people.
Exactly.
Make the drug that is preferred and cheapest for the plan the lowest cost for the patient, and make it a low cost and predictable cost. You know, patients are sick when they're searching out these drugs, and they don't probably want to spend all of their time trying to find the best deal. They want to just be treated and get well.
I agree. Thanks. I'm over my time. Thank you.
Thank you. Senator Warren.
Thank you, Madam Chair, and again, thank you for having this hearing. According to a recent Kaiser Family Foundation poll, 1 in 4 Americans have difficulty paying the cost of prescription drugs, and 30% have skipped some of their prescription medications over the past year because of costs. Meanwhile, the drug companies that make the drugs, the insurance companies that are supposed to help pay for them, keep raking in record profits. Families are the ones who are paying skyrocketing costs. Now, as Senator Casey discussed, we need to tackle out-of-pocket Medicare beneficiary costs for out-of-pocket Medicare beneficiaries. But out-of-pocket costs are also a problem for patients with private insurance. And I hear all the time from constituents who have private insurance, but who are still struggling to pay for their prescriptions. Ms. Gill, if a patient is taking a drug and wants to shop around for an insurance plan to make sure that she picks the one with the lowest out-of-pocket cost for that particular drug, is it easy for her to get accurate information?
I'm going to make this answer really short. If she has an employer, she's not able to shop typically. So she is given she may have an option between health insurance plans, but typically they roll up into a single pharmacy benefit.
Oh, interesting. Okay. So let's say she's in a private market, so she's looking in the marketplace, she's in an ACA marketplace, whatever it is. She's in a marketplace and she has picked a plan that looks like it is the lowest copay on a drug she needs. Is the insurance company prohibited from changing that drug's copay after she has enrolled in the plan?
In 46 states, they can do whatever they want.
Okay.
So a consumer is at the mercy of those plans.
So the shopping is hard to begin with, and in some places you can't even shop. Even if she can shop, they can change it after
Absolutely.
she has purchased. So we know that the insurance company might jack up the cost of the drug, maybe because the drug company increased the price, or maybe just because the insurance company felt like it. But at least, will the insurance company have to keep covering the drug?
In Texas, yes, which is
we have a lot of states,
right? But that's really there are a couple, and you know, anyone else who's an expert here, Jane, maybe on state law, it varies by state, but typically no. So, a consumer truly is at the mercy of what a pharmacy benefit manager is going to do. And, you know, and when we use the term jack up the price, what we really mean is they can decide to drop coverage of the drug altogether. They could decide to move it on a tier. Most consumers don't really even understand what tier means. I think that's one of the problems. And so the consumer is also not able typically to shop around afterwards looking for another plan. So they're locked in for the year.
So even this highly motivated patient who really puts a lot of energy into shopping,
right.
The answer is she has multiple ways she could get stuck at the end of
Absolutely.
the day with very high copays. So, Dr. Dziecinna, let me just ask, how does it impact patients when the copay on a drug rises mid-year or a drug gets dropped from coverage?
So we know from a lot of research that when patients face a price shock, so when their price goes up suddenly, that a lot of them will walk away without filling their prescription drug, or they may take less than they should. So we know that this happens. In fact, this has been studied quite rigorously under the old version of Medicare Part D, where we had the donut hole, where you'd see patients hitting this high out-of-pocket spending at one point in the year, and they would just quit taking their drugs until the beginning of the next calendar year. So
All
it's
right.
very bad for patients.
So the drug companies keep jacking up the prices. The insurance companies keep shifting the coverage so that more of the cost goes over to the patients. System works great for everyone except families who either go without appropriate care or sink into debt. We got to tackle these problems head on. Now, I'm going to be reintroducing my Consumer Health Insurance Protection Act, which cracks down on a whole list of shady insurance company practices that they use to avoid covering prescription drugs. Two of the provisions in the bill I'm reintroducing are capping out-of-pocket drug costs at $250 a month for individuals and $500 for families, and banning insurance companies from dropping a drug in the middle of the year, not just in one state, but nationwide. You know, this just seems to me, this is the moment. We've got to be putting patients first, and that means putting an end to the greedy practices of insurance companies that are leaving patients without the coverage that they thought they were getting. Thank you. Thank you, Madam Chair.
Thank you. Senator Blumenthal.
Thank you, Madam Chairwoman. I want to begin by thanking you and Ranking Member Casey for bringing the issue of prescription drug costs before the Aging Committee again. It is a subject that we've discussed before and rightly deserves our attention again. This issue is of paramount importance, particularly to seniors in Connecticut and across the country. Drug prices are far too high and rising even higher. And what strikes me is how little we have succeeded in doing about it. Last week, I reintroduced the CURE, C-U-R-E, High Drug Prices Act, which would hold pharmaceutical drug companies accountable for price increases that are unjustified by any cost increases, and would provide a mechanism to oversee those prices so that the Department of Health and Human Services could limit them to 10% a year, 20% over 3 years, 30% over 5 years, unless there were some fact-based justification for them. I know that kind of price restraint mechanism sounds draconian, particularly to people who believe in the free market. I believe in the free market, but I think we've reached the point where we need to send that kind of message. I know that Senator Casey asked a little bit earlier whether transparency alone could bring down prices, and I understand that, and thank him for raising that issue very directly. I'd like to ask Ms. Horvath whether, and the other members of the panel, whether you agree that this kind of action may be necessary to bring down drug prices more than just transparency.
Your bill that you have dropped in, yeah, I think it will. Almost by definition, it will. So but the one thing then, it has always seemed to me that if you're going to focus on price increases, you also then have to focus on launch prices, because a company who understands that, their capacity over the patent life of the product to increase the cost over that patent life is going to be limited, is going to front load and produce a higher launch price. So that's
a really very good and important point, and I see you are nodding, Ms. Busesima.
Yeah, that's right. I think that is exactly right. I do also applaud the idea of being able to use transparency efforts to understand real drug price increases and thinking about how to try to limit those price increases, but completely agree that if you put a signal out that you're going to start clamping down on drug price increases then and not doing something about launch prices, you will end up in a probably same or worse position.
Any other members of the panel have thoughts about that issue?
I will say Consumer Reports, I believe, is on the record the advocacy arm of Consumer Reports as supporting the CURE bill, and I think that would be important. Transparency goes a long way for everybody, and certainly for consumers.
And let me just ask, in the minute I have left, do you have any thoughts about the launch price issue? How best to achieve transparency and some constraint on the levels of pricing?
Manufacturers properly, to some degree, focus on the value of their drugs. And most drugs are really invaluable to the quality of a person's life or even their life writ total, but they're not affordable. And I think we need to start making a distinction between affordability and value. And I think we need to move the discussion to affordability and away from value, because there's lots of things in life that are invaluable to, like clean water, but it is affordable for people to be able to pay their water bill in most cases. We need to start thinking it more in those terms.
Yeah, I might just in conclusion say what concerns me is not only the launch, but in a sense the relaunch, where the patent process may be abused and an old drug may be put in a pill of a different color and a new patent obtained, and thereby generics kept off the market and prices increased. I know this is a vast oversimplification, but I think it is a real problem, and I want to thank the witnesses, and thank you, Senator Collins, Senator Casey.
Thank you. Senator Braun.
Thank you, Madam Chair. Transparency is one thing. Actually, the people that use the system embracing that transparency is another thing. 10 years ago, when I took on the whole gamut, not just prescription drug prices, but basically health insurance being so paternalistic, giving us so few tools to use, I can tell you it took a radical system change within my own company with a little bit of wishful thinking to make sure it was all going to work. So we set the stage for using the meager transparency tools that were available, but trying to create a culture where we emphasized prevention, not remediation, and just engagement among my employees in their own well-being. So we basically, in the process of trying to find that transparency, which was so opaque 10 years ago, we actually were able to. But it took a little bit of coaching and encouraging through some skin in the game among our employees before they really looked hard. Because with low copays, and any of the panel, I'd love to hear your thoughts on this, which keep skin out of the game, how do you make that big jump to where if you do have transparency, that you can even get the people using the system with copays to use it? Because we couldn't really get much traction on lowering healthcare costs until we crossed that big divide. And when we did, things started cascading to where we started saving a lot of money. So how do we get a paternalistic system, the people that have been using it, to embrace transparency when you've got things like copays? Any of the panel that would feel comfortable answering that?
So I think the first step in that is just helping the patients understand and the caregivers understand even what they're going to pay. I think we heard yesterday just a lot of confusion about, I get to the pharmacy and I don't even know what I'm going to pay that month. So I think part of it is just giving the tools to the patients and the caregivers to even understand what they're going to be paying out of pocket. And once you do that, then you can start maybe putting in some of those incentives or things that will actually get them more skin in the game. But I think at this point, there's just so much confusion out there that you're not even going to get to that point that you want to get to yet.
So most plans do have copays, and if a copay is only $10 or $20, do you think they'll even make the effort of trying to shop around?
I think at that price, maybe it's not worth it, but I think we're hearing enough, and with more of the specialty medications that are coming into the market, you're seeing more and more of those copays, and you're also, with the high deductible plans, even when you have a low copay, it's not necessarily, to me, I think the plans have changed enough that you're not even seeing those low copays anymore, just because of so many of the high deductible plans that are out there.
Okay.
One of the things that you could do as an employer are things like reference pricing, which is a strategy that is being used in some cases to say, you as the employer or insurance company have picked a low price product for you as the preferred drug. You set that cost really low for the patient. And then the other choices are much more expensive. So it really helps to align what patients are doing with what's the lowest cost for the health plan and hopefully the highest value overall. So that's something that has been tested and is being shown to work in some employer-sponsored benefits, for example.
I'd love to say, too, shopping around is not necessarily the actual goal. It's indicative of a problem. It's a symptom of an illness in our system. We, as reporters, try to help people find ways to shop, but it's only a workaround to a really terrible problem. The issue, though, you're asking about copays and to the point, the skin in the game concept. When I hear that, what I hear is an insurance company or a PBM pointing a finger at you, telling you guys are using us too often. My advice actually to any employer would be to turn around and go back and say, there are 3 or 4, 5 provisions that we want to see you be better for. We want you to be a fiduciary for us. We want you to help us, not just simply put it back onto an employee's, truly they're a burden, an administrative burden, also a shopping burden, to try to figure out what's the best deal that this insurance plan is offered.
It's a great point. I'm out of time here, but during that whole journey, I've been talking about the industry itself. If they want to save themselves from one business partner, the federal government, they better get with it. And I would admonish anybody in the healthcare business to start being proactive, do these things so it isn't so difficult for all of us, whether you're through government paid healthcare and especially the private arena, get with it. Thank you.
Thank you very much, Senator. Ms. Horvath, at yesterday's hearing, we heard from witnesses who are having trouble affording the best treatment for their individual health care needs. One witness was prescribed a PCSK9 inhibitor, and similar to 75% of Medicare beneficiaries who are prescribed that, she could not fill it because of the high out-of-pocket costs. Another witness with type 1 diabetes from my home state of Maine could not afford the continuous glucose monitor and pump that she needed to keep her diabetes under control. Now, the irony and tragedy here is the woman from Maine was ending up with costly monthly emergencies. Yep. She was going into, she was literally falling unconscious while driving because of low blood sugar. She had repeated hospitalizations, all of which cost the insurer more than if they had paid for her continuous glucose monitor and pump, which would have prevented these terrible incidents. So I know that some insurers are experimenting with value or outcomes-based contracting. Can you give us any assessment of what those arrangements have produced so far? How can we solve this problem of insurers being unable or unwilling to pay for essential treatments, and yet they'll end up paying more for hospitalization that results?
So, the question of value-based contracting, I think the jury's still out on that. I personally, and I don't think I have a widely shared view here, but again, I personally think that when you start talking about value, you're in the manufacturer's ball game, right? Because their drugs are highly valuable or invaluable. So I worry about that. But in terms of how these value-based contracts have worked out so far, I don't think we know. Most of the contracting is pretty proprietary between the manufacturer and the state. I'm looking at state Medicaid agencies that are doing this. The only thing I would say is that years ago, and not that many years ago, like 15 years ago, there were no drug deductibles. Drugs got first dollar coverage under your insurance benefit. Like, we didn't have any of the zooiness. It's because of prices. It's insurers trying to manage the prices. And, insurers know that that's dumb, what you just described, and almost nonsensical, except for the fact that that just then gives the manufacturer free rein to increase the price of their stuff twice a year, 3 times a year. It's limitless. So, again, insurers know that this is a crazy system and that beneficiaries suffer. And pharmaceutical manufacturers do, and device manufacturers do. They've built their model on price instead of units sold. It's been a whole shift in the industry in the last 15 years. Their profit structure is built on the price of the product, not how many bits of the product they've sold. And if we got back to affordability and selling more at a lower price, we wouldn't have this tug of war between insurers and manufacturers, and we wouldn't have poor consumers in the middle. But it gets back to price.
Thank you. Dr. Doucette-Zena, I want to get back to the price issue with you and the role that our patent system plays. The National Academy's report highlighted anti-competitive tactics that extend patent protections for approved drugs. The Hatch-Waxman landmark law provided a pathway for the approval of generic small molecule products, and today generics account for 90% of prescriptions in that area. But uptake of biosimilar drugs has been much slower, with patent litigation and settlement agreements blocking market entry for many FDA-approved biosimilar products. So that's what I want to focus on. We had a hearing on it. We looked at Humira, what happened with that drug. This week, Senator Kaine and I introduced a bipartisan bill, the Biologic Patent Transparency Act. And what it does is require the makers of biologics to publicly disclose all the patents that protect their products. So the idea there is it would give the prospective biosimilar manufacturer the information they need to know what they're getting into and also to challenge weak or invalid patents earlier in the process. Perhaps a more important provision would prevent or deter the brand name companies from filing patents late in the process with the sole intent of delaying market entry. And that's what has happened, it appears, with Humira. So tell us what you think of that idea. Do you think that if we had changes in our patent laws that it would help get the products to market sooner without discouraging the innovation that we all want to pursue and for drug companies to pursue and manufacture drugs that are really going to make a difference?
That's a great question, and I appreciate that. So for biosimilars, they are just going to be more expensive to develop than small molecule drugs. The approval pathway is more complex, so it's just more expensive to get those drugs onto the market. That means that they have not quite as large of a price reduction as we would typically expect with traditional generics. So that's why I think we're seeing slower uptake and less formulary coverage for biosimilars than what we would hope. So I think any steps that you take that would make the path to developing those products easier, clearer, less risky will probably help to make that pathway smoother for those companies and potentially could lower their prices ultimately.
Thank you very much. Senator Casey.
I just have one question for Ms. Gill. I've been thinking about your testimony and the work that you had done on the Medicaid or Medicare Pathfinder tool. We know now that CMS has recently announced they're going to be making some improvements. If you were designing or itemizing recommendations this committee could make to CMS as they consider those improvements, what would you recommend or suggest to us?
Wow, I appreciate that question. Thank you. I would say, based on our investigation, just being able to see what's a preferred pharmacy in your area would be really helpful to a consumer. The other thing that we saw from the investigation is that being able to compare more than 2 pharmacies at a time would also be extremely helpful. Perhaps even looking at looking at different zip codes. Many people don't just shop in the area in which they live. There can be quite dense zip codes. At the same time, being able to very clearly show how well the drug is covered, and not simply by things like tier 1, tier 2, or a preferred generic versus generic. These things have no real meaning to a consumer. You really need to see the total price and highlighting what that is. In my testimony packet, just by looking up a single pharmacy, a single plan generates over 9 pages of documentation trying to really untangle how difficult, honestly, almost impossible it is to try and pick a plan. And I'd love to mention, we ask seniors to do this every year because the plans change so often.
That's very helpful. Thanks very much. Thank you, Madam Chair.
Anyone else want to comment on that excellent question?
I would just add, and again, I know you're focused on the dashboard for Medicare, but there's the problem that we're facing with on the real-time benefit check is, at least on the commercial payers, is the patient out-of-pocket cost isn't standardized, and so that's one thing I think that you would want to make sure is, depending on which plan you're looking at, the standard. Like you standardize the patient out-of-pocket cost information, but also I want to point out the specialty meds. Again, I'm not quite sure exactly how that's covered with Medicare, but if it's covered under the medical benefit, you want to make sure that that information is available as well.
Thanks.
Thank you very much. I want to thank all of our witnesses today. This has been extraordinarily helpful as we tackle this very vexing and important problem. This is the second of our 3 hearings this round. We've done a lot of work in this area in previous Congresses, but your expertise is invaluable. You've given us a lot to think about how to empower consumers to access the best prices for their medications, and ideas on how to fix what is clearly a broken system of misaligned incentives that encourage higher pharmaceutical prices. One of the issues that makes this so difficult is when I heard the testimony yesterday and one of the witnesses who said that she's gone $10,000 in debt to afford her prescription drugs. And she's on the Medicare program, she's a retiree, she has good insurance as a supplement, yet she's $10,000 in debt. And I just think that's wrong. And it's interfering with the quality of her life in the years that, as she points out, she has left. And my first thought was, well, why isn't there a cap on the out-of-pocket costs in the Medicare prescription Part D program? And I was surprised that there was not. When you get to the catastrophic level, obviously the federal government's paying a far greater percentage, but there's no dollar cap, at least that I can find. And that was a real surprise to me when I heard her testimony. And so first I thought, well, we should put in a cap, and perhaps indeed we should. Then I started thinking about it, and even if a cap is a good idea because it helps consumers, it doesn't address price. And all it does is shift who's paying. At least that's my initial analysis. So I think that's an example of just how difficult untangling the web is for these prescription prices. Our next hearing on the topic is going to be a deeper dive into the efforts of the administration to tackle this problem, and I commend the administration for focusing on it, for coming up with a proposed rule, for looking at the rebate issue, and we're very eager to hear from the administration. I'm very disappointed that Dr. Gottlieb from the FDA is leaving, because I believe he is very committed on this issue, and he's implemented the law to try to expedite the approvals of generics, and has done so with great passion. So he was supposed to be one of our witnesses. Unfortunately, he will be gone by then. But I am hopeful that we can keep looking at all the steps, small and large, that we might be able to take, and that there will be, and I think you heard it today, a bipartisan consensus that this issue must be tackled, and that we can at least take some initial steps that will make a difference. And to me, it's a good sign that the patent bill that I introduced this week has bipartisan support from Senator Kaine, Senator Portman, Senator Shaheen, Senator Braun, and Senator Stabenow. I'm very glad to join with Senator Casey on his dashboard bill as well, and increasing transparency. So I would ask that you keep your ideas coming forward to us, because I think this hearing is very helpful and helps educate people on the challenges that we face. And I'm grateful for Consumer Reports doing the kind of analysis, because, you know, let's be realistic. The average consumer just sees this bewildering array of plans, and when you look at the ACA plans and try to figure out which one you're better off in, or and then you've got the pharmacy issue on top of that. And I agree with Ms. Gill when she said that these terms, preferred generic, preferred pharmacy, really don't mean a lot. We need clear pricing data that's not so hard to access, and I'm pleased that the state of Maine is helping to lead the way in that area. Senator Casey, any closing thoughts from you?
Just briefly, thank you, Chairman Collins, because we've had 2 days now of a more intensive focus on this issue, both from the perspective of individuals impacted and unfortunately adversely impacted. And today we were able to get to a good discussion of a lot of solutions. So we're grateful that there's no shortage of ideas out there, and we obviously have more work to do, but I'm grateful for your willingness to not only lead on this, but to have these hearings. One of the things that I think this hearing further affirms is the value of in-person counseling programs like the Medicare State Health Insurance Assistance Programs, or so-called SHIPs. In Pennsylvania, we have a different acronym by the name of a PRIZE to help folks navigate some of these issues. We can't be expected to navigate this complex web of Medicare coverage and prescription drug prices without help, and we all need help to understand this challenge. I am pleased that we've put forward today, and will continue to put forward in a bipartisan fashion, common sense, thoughtful policy solutions. that will help bring down the cost of medications, and we have to follow up the hearings with actual solutions by way of taking action. And I think, Chairman Collins, you're right. This is a bipartisan concern, and I think it's a concern that people in both parties, both houses, are realizing they ignore at their peril. And that's motivating the focus, and we hope will motivate the solutions and ultimately the actions. Thanks very much.
Thank you. Committee members will have until Friday, March 15th to submit additional questions for the record, so there may be some coming your way. Again, I want to thank each and every one of you for your work in this area and your participation in this hearing. Together, I truly believe we can come up with some solutions that will make a real difference to the patients we heard from yesterday, who are representing literally millions of